In the Western Cape of South Africa, over 5 million active patients access health services in public sector hospitals, primary care facilities, and in the community. In 2019, there were 19 million patient contacts with the health systems.
The biggest challenge managing the healthcare of the patients in the Western Cape is the mismatch between the service needs that the public has and the resources we have available. We have what we call the quadruple burden of disease, which is maternal and child health, TB, HIV, violence and trauma, and chronic diseases. What happens is it causes a lot of pressure on the health services. Now the question is, how do we create the most effective, efficient, and equitable system that will meet the health needs of our population?
When you're dealing with information of patients, their background history is absolutely critical in the discipline of making diagnosis, decision-making, and future therapies. Very often, the bulk of the responsibilities was to how we would go about getting this information. Due to patients being so unwell, they would be unable to answer those questions themselves, and frequently the only way we could do it would be to call family members, try get a telephone number for them, and the next time they would be coming to hospital, we'd have to ask them to bring the medication that was at home with them. This would be really tough with a very high workload to repeat this for multiple patients, and often would result in it not happening at all. Often our teams would neglect it and our decisions would be made on presumption, but not on hard evidence of what had happened before.
The Single Patient Viewer, or SPV, was initially developed as a prototype web application, which allows the rapid retrieval of all digitally held administrative and clinical information for a given patient, primarily for clinical use.
The Western Cape has introduced a patient master index, where every single patient in the Western Cape gets given a unifying number by which multiple services are tracked and kept together. For example, all of their clinical bookings and attendance to hospital would be referenced under this number.
The Single Patient Viewer platform uses that number to pull in data through the PHDC from all of these disparate electronic systems. Some of them are lab systems, pharmacy systems, many of them not online, and all of that data that gets pulled into the PHDC is linked up using this PMI number and then is surfaced through the Single Patient Viewer.
The beauty of Single Patient Viewer is that it's able to draw information from all these different standalone systems and collate it onto one specific platform. It does so in an easily digestible way. You can formulate a picture of your patient irrespective of whether they were seen on Saldanha Bay all the way on the west coast or down in George on the other side of the province.
SPV is also used by some program and information management staff for data verification and for assisting in patient follow-up.
My name is Portia Hendricks. I am part of a research team for the Desmond Tutu TB Centre. On a daily basis, I draw a TB cascade, and what I do is I normally alert the manager in the IPC department that there are patients that are admitted to the hospital who are TB positive. For instance, this morning I found that there were 2 patients that were initially tested at a facility that was admitted to hospital now and not on treatment yet. It was easy for me then just to alert and make sure that the patient then is put on treatment if they require treatment.
The high-level architecture of the Provincial Health Data Centre is illustrated in this diagram.
Data are ingested from a number of different disparate data sources. These are either other databases, files, various different kinds of formats, from Excel to XML, and even transactional sources. The transactional data comes in real time and gets put into a holding database through an interoperability layer. The other data is ingested either daily, weekly, or monthly, and put into the staging database. All data then goes into the archive database so that we can keep a record of where it came from and reload it if we need to. And then there's a process of linking all of the data and processing and cleaning it. The data from there is moved into a number of databases which are operational. One is the patient database, which contains all the demographic information. The other is the clinical database, which contains only clinical data and no demographic information. And then there's other databases like reporting, facility, community, provider, and administration. The data are then available through a number of different portals. The OpenHIM, which is the interoperability layer, is used for real-time access to the data. And then there's also a reporting framework which is used for the analytics, and that's Power BI, SQL Server reporting services, and manual queries to the SQL Server database. There are a number of data outputs that we get through the reporting framework and the interoperability layer, one of which is the single patient viewer, which gives a longitudinal view of a patient's clinical history. There's also patient-level reports, alerts, management reports, and other kinds of extracts, for example, for research purposes.
With the onset of the COVID-19 pandemic, new demands on the health system led to rapid development of additional functionality in SPV, specifically for recording of cases and contacts.
What has been extremely useful for me is using the COVID line list within SPV. So my role is to essentially make sure that the staff are taken care of, because healthcare workers are at higher risk than the normal community from contracting COVID-19. Previously, I had readily, easily available information for staff who had tested in the public sector, but staff who had opted to test in the private labs, I didn't have access to their information. So the amazing thing about the single patient viewer is that it collated all this information from the different resources in the province, from the private sector and from the public sector, and I could quickly identify staff who had COVID-19 that I needed to respond to. So using the COVID-19 healthcare worker line list has been very helpful for me.
We can build COVID-19 systems where we can analyze the patterns of admissions, the patterns of deaths, the patterns of infections, and we can actually start to track the epidemic and actually have an understanding of what is happening with COVID-19. Its initial use was to understand the history of the patient, but it's now got far wider reach at this point.
One very important aspect with contact tracing and with the management of people with COVID-19 is that you have to try and risk stratify. By risk stratifying, I mean that you have to try and identify people who have COVID who may be at a higher risk of having more severe disease so that you can give them more support. The diseases that we've obviously been worried about in COVID-19 are the comorbidities such as TB, HIV, and diabetes, etc. You can see whether there's a possibility or that there's evidence that this person might have diabetes, which means that the kind of management and support that you would give to that specific individual would be slightly more intensified as opposed to somebody who's younger and probably has no comorbidities. So the single patient viewer is really helpful in doing the risk stratification when you're looking at your patients.
By early 2020, SPV was an extended pilot phase with over 200 clinicians using the portal, either for clinical care provision or for clinical audit activities. The application had evolved to include referral, follow-up, voice call and messaging, and reporting functionality.
We use the follow-up tab on the SPV to create an SMS. We use the call patient facility, and we phone the patient through the SPV.
So it's really easy to access the single patient viewer. I can literally use it at home from the comfort of my lounge.
The SPV has been developed for global public good and will be made freely available once matured. It is radically changing the way clinicians in the Western Cape are able to deliver care.
At this point in time, we've only looked at what we can do retrospectively. What has happened for a patient? Where did they get care? What medication was given? But from here, we can do so much more with what we can provide a patient.
We could develop patient-facing applications so that if a patient wants to look on their cell phone and put in their patient master index, they could automatically pull out all their health records. So instead of a patient having to come into a health facility, we could interact with them through the SPV onto their device, and we could discuss their hypertension, diabetes, TB, HIV. There are various applications, but it's really about creating a stronger interaction between the patient and the service provider.
We know also that with single patient viewer, a lot of time that was spent trying to obtain and get this information is now made directly available to the clinician to be at the bedside caring for patients. We don't want to be tied down with bureaucracy. We want to be caring for people. This has had a huge impact on the amount of care that we can provide for our patients.